Well, good afternoon. Hi, everybody, and welcome to the webinar. My name is Mohammad Jalili, and I'm the host of this session of the webinar. This is the second session of the webinars organized by Tehran University of Medical Sciences under the title of COVID-19 case presentation and panel discussions. The topic of today's discussion is about critical care in the emergency department. We'll briefly discuss the different aspects of critical care in the emergency department as pertains to the patients who are suffering from COVID-19. But first, let me start with the introduction of our guests today. We are deeply honored today to have a very special guest, Dr. Zehtabchi, who's a very distinguished professor of the emergency medicine at the State University of New York and works as a clinician in Kings County Hospital, where he sees a lot of COVID-19 patients these days. He's a very well-known scholar with many academic positions and scientific production on his profile. His center is now one of the busiest centers active in caring for COVID-19 patients throughout the United States. He has kindly accepted to join us today, and we thank him. Other experts on today's panel are my colleagues from Emergency Department of Tehran University of Medical Sciences. They work in TUMS affiliated hospitals, Dr. Hadi Mirfazaelian, Dr. Elnaz Vahidi, and Dr. Arash Safaei. They have all seen a lot of patients, COVID-19 patients, over the past 2 or 3 months, and they have very good insight and a lot of experience with these patients. Before I move on to the case presentation, I would like to thank the Deputy of Global Strategies and International Affairs of Tehran University of Medical Sciences and the technical staff for helping us with having this webinar. I would also like to thank our panelists who've kindly accepted to take some time out of their very busy schedule to be with us today and share their knowledge and expertise. I also want to thank the audience who have joined us today and will help us to have a better webinar by their thoughtful questions and sharing with us their experiences. I should also disclose that the dearth of knowledge in the field makes robust evidence-based recommendations almost impossible, and the information which is provided here is based on the best available evidence as the day of the webinar. The panelists are sharing their own experience and knowledge and do not represent Tehran University of Medical Sciences or any other formal authority. The panelists have declared no conflict of interest for this. This slide shows the current situation of COVID-19 around the world as of May the 6th. And as you see, the number of deaths in Iran has exceeded 6,000, and we have around 100,000 patients with confirmed COVID-19. And we know that the number must be much higher than this. So let's start with the case presentation. Those who've been with us during the first session of this webinar, remember this 36-year-old man. He came with signs and symptoms suggestive of COVID-19, and based on his history of multiple sclerosis, which was being treated with immunosuppressive medications, underwent a CT scan, and the CT scan at that time was normal, but because of his high-risk factors, he was treated with hydroxychloroquine and discharged home. He has now returned after a few days with a high-grade fever, cough, and dyspnea. And well, he's been taking his medication for 4 days, but he hasn't improved and has actually become worse. And physical examination reveals respiratory distress and crackles on lung auscultation. The patient is a COVID-19 case which has failed outpatient treatment, and his conditions are rather severe right now. And there are a lot of questions in front of us as clinicians. We want to know about the treatment options which are available for this patient and similar patients. And we want also know to how much evidence do we have actually regarding the treatment. What can we expect to see in the lung CT scan of this patient at present? And how would you help the patient with breathing? How would you support the breathing of the patient? If the patient needs intubation, what considerations are to be kept in mind? And if mechanical ventilation is needed, what would happen for that? So, and in case of resuscitation, what are the considerations that you should have for this? Well, our first speaker would be our splendid guest, Dr. Zehtabchi, who I want to ask to discuss with us the treatment options which we have for patients with COVID-19 who need admission, who are suffering from severe disease. And we'll be listening. And I ask you, the audience, to kindly write down the questions they have in the chat box of the Zoom, with sending the question to everyone. And then we'll collect the question and answer them at the end of these presentations. Dr. Zehtabchi will be hearing you.
Honored to be part of the discussion today. I also would like to thank Dr. Jalili and also Tehran University for giving me the opportunity. Sorry, please allow me to share my screen. Can you see my slides, Dr. Jalili?
Yes, your slides can be seen.
Okay, very good. Thank you. I've been asked to discuss the critical care management of patients with severe COVID-19 in the emergency department, and I will briefly examine the evidence behind some of the treatments that are available to us. As Dr. Jalili pointed out, what we talk about today are at best practice recommendations based on our experience in pandemic and experience that has been shared with us from different physicians, different institutions, from different countries, including Iran. Some of the recommendations are also local guidelines that we for example, in our institution, we sit down with our colleagues from emergency department, internal medicine, intensive care and infectious disease, and we develop some of these recommendations. Most of these recommendations are not based on high quality evidence because we don't have much evidence on these topic, and most of these, what we talk about today, might change when we have randomized controlled trials published. As you know, in the past 5-6 months, many papers have been published on this topic, a lot of case series, retrospective studies, and trials with small sample sizes. These are, of course, desperate times, and everyone is looking for ideas, and these papers are at best ideas, or what we call in research, they are hypothesis generating. So they generate hypotheses that can be tested by randomized controlled trials. So be mindful that we cannot draw strong conclusions from many of these papers because of their methodological limitations. But many journals are publishing these because, again, everyone is desperate for some ideas of how to treat COVID. I divide my talk on critical care management of COVID into two categories. First, I will talk about aggressive treatment of hypoxia, and then we'll quickly touch on some of the pharmacological treatments that are available to us. In the case of a patient that is presented here, I don't know what the patient's O2 sat is, but I assume he's hypoxic. And our first recommendation is awake prone position or proning. Asking the patient to lie face down on their chest and abdomen allows recruiting some of the dead space in the lung areas that are not being ventilated because of atelectasis. And this improves oxygenation very quickly. And also it allows for better management of secretions. So we had a great experience with proning of awake patients. And what we see is that O2 sat quickly improves when they lie down. This is all assuming that the patient can tolerate proning. And while the patient is prone, you can put the patient on oxygen or on high flow oxygen. This is, of course, has to be tested in RCTs to tell us whether proning actually impacts the outcomes of the patients. At the beginning of the pandemic, we saw many patients who were very hypoxic. They had oxygen saturation in the 70s or low 80s, but appeared really, really well. They appeared very comfortable. So our first reaction was to leave them alone. So we put them on oxygen and we observed them. Unfortunately, we found out that many of these patients developed respiratory failure later. Many of them required intubation and many of them died. So we concluded that this silent hypoxia is actually, or prolonged hypoxia is a risk factor for developing respiratory failure and multi-organ failure. So we decided to change our strategy and treat the hypoxia more aggressively. What we do is we use different steps of treating hypoxia by providing oxygen supplementation. First, we generally start with nasal cannula. And if the nasal cannula doesn't improve the oxygen saturation above 88 or 90%, we move to high flow oxygen. And if that doesn't work, we move to non-invasive positive pressure ventilation and put the patient on CPAP or BiPAP. And then if all of these fail, we of course have to intubate the patient. Again, at the beginning of the pandemic, the recommendation was to intubate the hypoxic patients early because the fear was that aerosolization from non-invasive ventilation could put the staff at risk of contamination or transmitting the infection. However, very early on, we realized that a majority of the patients that we intubated ended up developing ARDS and multi-organ failure, and many of them died. So we kind of stepped back after the first few days of pandemic and decided to give non-invasive ventilation a chance and try to avoid intubation as much as we could. I know that another speaker is going to talk about intubation versus non-invasive ventilation, so I won't go into details, but we've had a great experience using non-invasive ventilation for hypoxic patients, and we have managed to avoid intubation in many of these patients, assuming that they can tolerate it. Moving on to pharmacological treatments, we have several topics to discuss. We will discuss corticosteroids, antiviral, anticoagulation, and convalescent plasma. The first one is corticosteroids. As you know, there is really no indication for using mild to moderate, to use corticosteroids in mild to moderate COVID-19. There hasn't been any benefit shown, and also there's a possibility that giving steroids to these patients might increase viral shedding. So we tend to avoid using steroids in patients with mild COVID. But we do use low-dose methylprednisolone or dexamethasone daily for patients with severe COVID-19. And in those patients who are in cytokine storm, we give them high-dose steroids. This is not based on high-quality evidence, and I'm sure randomized controlled trials will tell us whether any of these are correct or not. Going back to cytokine storm, as you know, some of the COVID-19 patients develop an excessive, exaggerated inflammatory response to the virus. And that's evident by release of excessive amount of inflammatory markers in the bloodstream. And many of these patients go to have multi-organ failure, ARDS, and many of them die. We really don't know who is going to develop cytokine storm, and we don't know how to diagnose it. But in many places, including our institution, if the levels of inflammatory markers are very, very high, we consider them in cytokine storm. So if the CRP, ferritin, LDH are very, very high, we assume that they're in cytokine storm, and we treat them more aggressively. There are a few antivirals that have been proposed to help in case of COVID-19. The first one is hydroxychloroquine. I think by now we all know, after release of several randomized controlled trials, that there's really no evidence of benefit from hydroxychloroquine. And a few recent trials have shown that there's possible harms associated with using hydroxychloroquine, and some even showed increased mortality. So I think everyone is moving away from hydroxychloroquine because of the absence of any benefit. Tocilizumab or Actemra has been proposed as a treatment option. This is a recombinant monoclonal antibody that is used to treat rheumatoid arthritis. But really the reason why we are using it in COVID is because some of the cancer immunotherapy patients who develop cytokine release syndrome, they respond to tocilizumab. But unfortunately, what we have learned now is that cytokine release syndrome that we see in those immunotherapies is a completely different entity from cytokine storm in COVID-19, and therefore tocilizumab might not really be helpful. We only have, I have only seen one case series on tocilizumab, but luckily we have several ongoing multi-center trials at the moment that hopefully very soon will generate the evidence we need to use tocilizumab or not. Remdesivir, I'm sure you have heard, it has gotten a lot of attention in the past few weeks. As you know, remdesivir initially was developed to treat Ebola a few years ago, but the clinical trials had conflicting results and the company stopped producing it. But then some case series showed that it might be beneficial in COVID-19. Several non-randomized trials showed no benefit, and last week we became aware of 2 randomized controlled trials that tested remdesivir to treat patients with COVID-19. The first randomized control trial was published in Lancet last week, and they randomized 240 patients to either remdesivir or placebo. And this study showed that remdesivir did not improve clinical symptoms in COVID-19 patients and had no benefit. Strangely, we became aware of another randomized controlled trial by a press release. And so this study that was done on 1,000 patients has not been published, has not been presented anywhere, has not been peer reviewed. But the US government announced that this trial has shown that patient allocated to remdesivir had faster days to recovery. So instead of 15 days, they recovered in 14 days. So we have to wait for this study to be properly presented, properly published, to draw any conclusions from it. But unfortunately, some concerns have been raised already about the methodology of this trial. As you know, in the United States, all trials have to be registered before they start recruiting patients. And this was the case with this study. And interestingly, the clinicaltrial.gov website keep track of every change that is made in the research design. And in this case, we noticed that 2 weeks ago, which was after the data collection and possibly after data analysis, that they changed the primary outcome of the study. It used to be a severity score that included mortality, intubation, hospitalization, and some other patient-centered outcome. But they 2 weeks ago, they removed that outcome, possibly because it didn't show any benefit. And they added a new outcome, primary outcome called day to recovery. And this outcome, day to recovery, was never part of the original plan or original design of the study. So this has raised some eyebrows, and it's something that in research methodology is frowned upon and is not acceptable. But again, we'll wait for the peer review publication, and then I'm sure there will be more discussion on this data. A quick touch on anticoagulation. We have noticed that many of the COVID patients with, especially those with severe COVID, are in a hypercoagulable state. We have seen a lot of pulmonary embolism, a lot of deep vein thrombosis, and we have noticed clotting of central lines and dialysis access. So there's definitely a phenomenon here that most of these patients are hypercoagulable. In our institution, we use D-dimer to decide who needs to be anticoagulated. Different institutions use different cutoffs of D-dimer based on the sensitivity of the test that they're using. Some use 2,000, some use 3,000. And if the D-dimer is above those levels, the patients get anticoagulated. We really don't know if anticoagulation improves outcome or not. And again, this is something that has to be tested by randomized controlled trials. And lastly, convalescent plasma. This includes transfusing plasma recovered from patients who had COVID-19 but have survived and have recovered. We transfuse this plasma with the hope of improving the outcome in patients with severe COVID, especially those who are intubated. We really don't have any evidence of benefit or harm, and we are waiting for several ongoing trials to shed light on this treatment, including one trial that we are doing in our institution. From what I have seen, it helps some people, but it doesn't help many others. So we have to see. In my experience, 2 of our colleagues who died last week, we lost one of our charge nurses and one of our ICU attendings, both of whom received convalescent plasma, and they showed no improvement, then they passed away. So here's my sample size of 2 that did not show any significant benefit. But again, this is something that we have to wait and see, and there is possibly some benefits in certain subgroups of patients, but that remains to be seen. In conclusion, early aggressive treatment of hypoxia without intubation, it has been shown effective in our case, in our experience. We now tend to use a non-invasive ventilation more liberally and use it to delay intubation as much as possible. We use corticosteroids for severe COVID patients, and more patients are getting anticoagulations because of the hypercoagulable state that they are in. Thanks again for having me, and if there are any questions, I'm happy to answer.
Well, thank you very much, Dr. Zehtabchi, for this presentation and very informative. Actually, as you mentioned, we are all waiting for good evidence to come out and show us what might be actually helpful in treating patients with COVID-19, but still at the same time, because of the critical situation most of our patients are facing, we have to do the best that we can do at present based on sometimes small sample trials or personal experience or anecdotal reports. So these were very good points, because we have had the same problem of changing from one medication to another. At the beginning of the pandemic here, even oseltamivir was recommended for patients, and then they stopped it. And then we relied heavily on hydroxychloroquine, and then a couple of antiviral drugs and so on. And the story with procoagulation is also very important, because we have seen a lot of patients with stroke or cerebrovascular accident, which seems to be more common these days. And some people somehow ascribe it to COVID-19 infection. But these are the things that will probably become clear in the future. But right now we have to just keep our fingers crossed for the patients we have, and hope that they will show improvement whenever we do something. We hope that they will actually show improvement, but we just hope, and no evidence behind it. The next thing that we are going to discuss is the imaging that we might expect from this patient. Our patient underwent CT scan the first time he came to the emergency department, but at that time the CT scan was normal. And now, because of the findings on lung auscultation by the physician and worsening of the respiratory conditions, the physician decides to do another CT scan. Dr. Vahidi will tell us what we might expect in these patients in their CT scan, and how can we use it. You know that here in our center, we use lung CT. We used to use this lung CT scan quite liberally, and we used it almost as a screening for our patients, because the results were became much more readily available than PCR or other tests that we had. So there's a lot of experience with CT scans here in Iran, and Dr. Vahidi will share with us some of those experiences. Dr. Vahidi.
Hi to everybody. Thank you for inviting me. It's my pleasure to be with you in this webinar. I was asked to give you a brief intro on CT imaging and differential diagnosis of COVID-19. Over the next minutes, we're gonna walk through these objectives. First, a short background about the role of CT scan in COVID patients. Second, its differential diagnosis. Then we'll see Kovac classification as one of the most important and popular classifications nowadays. And last but not least, we'll talk about Iranian Society of Radiology COVID-19 Consultants Reports template. For COVID diagnosis, we use different assessment tools. But the first key point to remember in mind is that you should always consider the clinical context. The other point, which is quite striking, is that X-ray has low sensitivity and specificity. PCR has also 60 to 95% from China to United States sensitivity. Thus, chest CT might seem a good solution for physician, but chest CT is just a part of patient assessment. It's really important to remember this in mind. And imaging findings are varied, overlapping with other infectious and inflammatory lung diseases. Main CT feature is ground glass opacity, which is partial or volar filling with increased density in the lung, and the vessels are still seen within the opacities. And it's typically had a peripheral and subpleural distribution. The other finding you might have heard is crazy paving pattern, which is thickened interlobular septa and intralobular lines with superimposed ground glass opacity. I should just one more time again focus on this part, that these findings I've just mentioned are characteristic but not specific to COVID-19. CDC does not currently recommend X-ray or CT to diagnose COVID-19 because CT is initially negative in 50% of cases, especially in mild cases. So the today recommendation is that do it in cases you have suspicion of superimposed infection. Of course, COVID had differential diagnosis in CT, like other viral pneumonia, influenza A, influenza B, CMV, adenovirus, RSV, SARS, or MERS. Non-viral infectious pneumonia, especially atypical mycoplasma pneumonia, non-infectious pneumonia, hypersensitivity pneumonia, interstitial pneumonia, or pulmonary alveolar proteinosis. Drug-induced pneumonia becomes similar to COVID-19, like patients under chemotherapy or immunotherapy. Cryptogenic organizing pneumonia, which is another form of idiopathic primary pneumonia. As you see in table 1, COVID-19 in early stages has the typical finding of bilateral peripheral ground glass opacities, and no discrete nodules or no pleural effusion, no lymphadenopathy, and there is a lower incidence of consolidation. But as the disease progresses, it tends to be more complement ground glass opacity and more diffuse. We might see crazy paving, architectural distortion, bronchiolar dilation, or superimposed consolidation, linear opacities. Consolidation is complete alveolar filling, and we usually expect to not see vessels within these opacities. Other viral pneumonia usually cause interstitial inflammation, high attenuation reticular pattern. But other bacterial pneumonia, streptococcus, or atypical pneumonia, mycoplasma, usually cause lobar pneumonia and multiple consolidation. So the differential diagnosis somehow is obvious. As I said before, Kovac classification is one of the most popular classification used today, CT scan was performed for most of our patients in Iran at the beginning of the epidemic. But day by day, we learned about the clinical presentation and other qualified tests. So in Kovac classification is a standardized reporting system for suspected COVID-19 patients, and it's usually used in moderate to high prevalence setting. It's graded from very low or Corad 1 up to very high or Corad 6 classification, and its interpretation is usually in combination with clinical symptoms and the duration of it. CT can be negative in first few days of a mild infection. Here we have a case, 25-year-old patient with complaints of fever for 5 days. It's Kovac classification 1, which there is no suspicion for COVID-19. And as you see, CT is normal, or there are findings that indicate a non-infectious process like sarcoidosis, histoplasmosis, malignancy, or etc. PCR of this patient was negative. Corad 2, like the patient we have here, case 2, is a 40-year-old patient with fever and coughing. Here there is low suspicion for COVID-19, and there are no typical signs of COVID in CT images. CT might show bronchiectasis, bronchial wall thickening, or tree in bud, as you see in arrows, which is multiple areas of central lobular nodules with branching pattern. Lobar consolidation and tree in bud consistent with bacterial infection is shown in this lower cut of CT scan. Corad 6, which is our number 3 case, which is a 50-year-old patient with recent influenza A and started coughing again. Here there is indeterminate risk for COVID-19, and there is widespread bronchopneumonia, lobar pneumonia, septic emboli with ground glass opacities, and there are bilateral central consolidation with diffuse ground glass opacities. The patient had a retest PCR for COVID-19, and it was again negative, but positive for influenza A. Corad classification number 4, a 57-year-old patient with history of emphysema and new complaints as shown in this CT scan. Here there is highly suspicious CT findings, but not extremely typical. There are bilateral ground glass opacity, and as you see, it seems that COVID is within some underlying disease in the patient. In this case, unilateral ground glass multifocal consolidation are seen without any other typical finding. PCR of this patient for COVID-19 was positive. Corad classification number 5 is 45-year-old patient with 10 days of complaints. Here, very high suspicion of COVID-19 is seen. It's important to see and be familiar with these findings in CT. There are bilateral multifocal ground glass opacities, vascular thickening, which is shown in circle, subpleural bands, which is shown with arrow, and bilateral consolidation, basal preference. PCR of this patient was positive too. And Corad's number 6 is a case like the patient we have here with dyspnea and accompanying positive PCR. There are bilateral ground glass opacities, and as you see, there is a hollow sign is shown with arrow, and is the consolidation within the ground glass opacity is a hallmark somehow for COVID-19 up to the research we have done today. And what about Iran? As you know, we faced and encountered this situation from the beginning. And Iranian Society of Radiology COVID-19 consultants, after reviewing and evaluating more than 1,000 CT scans of patients, decided to design an algorithm and reports template for COVID-19. And most of our CT scans are reported nowadays in this category. Findings which are highly suggestive for COVID-19 pneumonia are ground glass opacities, bilateral, multifocal, or unilateral unifocal, peripheral distribution, or less likely peribronchovascular distribution. As COVID progresses in later stages, we have a pattern of organizing pneumonia. As I mentioned before, reverse hollow sign or linear opacities in late stages. Findings which inconsistent with COVID-19 pneumonia are 3 in-body opacities, centrilobular nodules, predominantly pre-bronchovascular distribution, predominantly nodular opacities, predominantly reticular opacities, cavity, lymphadenopathy, pleural effusion, and of course, there shouldn't be any suggestive findings for COVID-19. Findings indeterminate of COVID-19 or absence of typical features and the presence of multifocal, diffuse, prehilar, or unilateral ground glass opacities, consolidations, lacking of specific distribution, and they are non-rounded, non-peripheral. With this description that I told you, for highly suggestive patients, we usually send them to some specified predetermined ward or ICUs. And for others, we usually decided to go further and examine the patient with other imagings or tests. What are our take-home messages? As I mentioned before, always consider the clinical context of the patient. Ground glass opacity is characteristic, however, not specific to COVID-19. And do CT scan in cases you have suspicion of superimposed infection or you are doubtful of some other differential diagnosis, and never treat the imaging alone. Thanks for your attention. I'm here to answer if there's any questions.
Well, thank you very much, Dr. Vahidi. We enjoyed the presentation. Actually, there's abundance of experience with CT scan here, as we did a lot of CT scans for our patients. I remember at the beginning of the pandemic when almost all patients who had either a risk factor or they had fever and the condition was deserved actually CT scan, underwent CT scanning, and a lot of imagings we saw with these COVID-19 patients. And as you mentioned, the classification proposed by the Iranian Society has also helped our radiologists to report the CT scans of these patients much easier and more consistently, which was very helpful actually for the clinicians. But again, the ideas vary depending on the specificity and sensitivity of CT findings. Most radiology societies have not yet approved the CT scan findings as the diagnosis, and the diagnosis of COVID-19 is still based on confirmation by PCR. But there are a lot of findings on lung imaging, especially by CT scan, which are very suggestive to the diagnosis of COVID-19. Thank you very much. The patient actually undergoes lung CT, and this time the evidence of parenchymal involvement by COVID-19 is evident, and the patient is hospitalized. During the course of hospitalization, the condition of the patient worsens and requires support, for ventilatory support. Dr. Zehtabchi already touched on the important considerations regarding the treatment of hypoxia in these patients. Dr. Safaei will tell us a little more about how we'll manage these patients, the area of these patients, and also how we will do the ventilatory support in COVID-19 patients, and will share with us the experiences he has in his institution. Dr. Safaei. Dr. Safaei, if you can hear us, we don't have your voice yet.
Hello, everyone. Thanks for your coming. I'm Arash Safaei from TUMS. I want to talk about airway management and ventilatory support in COVID-19 patients. Before I start, I'd like to mention that by living in an evidence-based era, most of my presentation lack strong evidence, most using the expert recommendations, guidelines, few case series and case reports, and our own expenses will present as well. This is the outline of what I'm going to talk about today. I'll discuss non-invasive means of oxygenation and ventilation, starting with low flow methods and then high flow devices, and finally protection measures for the staff. I'll talk about invasive means afterward, answering the question when to intubate COVID-19 patients, initial ventilator settings and rescue measures, and at the end I review protection and safety issues for the personnel. The recommended oxygen target for COVID-19 patients is the same as other patients, 90 to 96%, which represents a PaO2 of 55 to 80 millimeters mercury. Of course, there are true for pregnant patients. Most COVID-19 patients either do not need oxygenation, not at all, or low flow means are enough for them to achieve the aforementioned oxygenation goals. The low flow oxygen delivery methods include a nasal cannula, simple venturi, or non-surface mask. Physician should titrate delivered oxygen levels to achieve the desired target of oxygenation. If the low flow devices cannot maintain the desired oxygenation, one may choose to use high flow non-invasive methods of oxygenation that include oxygenation via high flow nasal cannula or using non-invasive ventilation. There are debates on choosing between these modalities, yet most others are trending toward using HFNC and reserving the NIV for patients with coexisting conditions such as acute exacerbation of COPD or acute cardiogenic pulmonary edema. Prone positioning can be used with any of these modalities. If using HNFC, try to use the lowest possible flow and FiO2, though the physician may commence HNFC with high flows and FiO2 should take to decrease both means as soon as possible, using the given ranges as a rough guide. As I told earlier, NIV was not associated with much success in this patient. It has the worst of giving a try in some patients. For the initial NIV setting, we typically start using CPAP with a low CPAP and gradually increase it, letting the patient get used to NIV. So using BiPAP was not associated with better results. Generally, we still use it in some cases of CPAP failure and in patients with acute exacerbation of COPD and hypoventilation syndromes from the beginning. Use low-high approach, usually starting with low EPAP and IPAP and gradually increase them. As a general rule, the more the oxygen flow, there's an increased risk of droplet production and aerosolization. This rule applies for all low flow methods of oxygenation and HFC. The recommended method of decreasing the degree of droplet production and aerosolization is to use a surgical or preferably an N95 mask over the oxygenation device. Valve mask must be avoided. Delivering medication using a nebulizer non-intubated patients associated with a high degree of aerosolization. This should be generally avoided if possible, and other routes such as MDI may be used. Experts recommend using either a good fitted full face mask or a helmet device with an anti-asphyxiation valve as the interface, and recommend against using nasal or orofacial masks or cushions interfaces because of the high risk of aerosolization with them. In our limited experience, patients have less agitation and better outcomes with full face mask rather than helmets generally. Nevertheless, it will be impossible to find a well-fitting mask. In some cases, we recommend using dual limb circuitry, no leak or exhalation valve, and HEPA filter on the expiratory limb. It's hard to give a unique answer to this question. Beside the intubation need of patients on a case-by-case basis, we have a large threshold for intubation in older patients with previous comorbidities, especially those with decreased lung or cardiac reserves. We prefer intubating most patients with hemodynamic instability, altered mental status, or multi-organ failure directly and not waiting for them to become more deteriorated. Additionally, we get our intubation tray ready when the patient has hypercapnia or signs of respiratory fatigue or distress. But we commonly give this patient's time and decide to intubate them based on their baseline characteristics and response to therapies. In other patients, we generally wait case with lack of improvement despite our best effort, or in those cases with deterioration, choose to intubate. There were some debates among the authors for early versus delayed intubation in COVID-19 patients. Support mostly the former, intubating patients earlier when they need it, when they do not improve with our best efforts. Here are the recommended methods of personal protection during intubation: using oxygenation with low flow means with protections I said earlier, and avoiding either HNFC or BMV as much as possible. The experts recommend using a HEPA filter between mask and resuscitator bag to prevent exposition of aerosols in the room. Always using RSI method and the video laryngoscope if available, running full PP and letting the most expert intubator to intubate this patient. Using an aerosol box seems to be an cheap solution to lessen the degree of aerosol disposition. Furthermore, we recommend clamping of the ETT and make ventilator and circuits ready before the intubation. Using a resuscitator bag on the left and using aerosol box on the right. The initial ventilator setting, we recommend choosing volume controlled ventilation and assist control mode, using a low tidal volume ventilation strategy like what we use in other ARDS patients, starting with a tidal volume of 6 milliliters per kilograms using predicted body weight and adjusting the tidal volume based on patient's lung dynamic characteristics. We use high respiratory frequency as high as 30, and the low flow letting and increase inspiration time and I/E ratio. We start the ventilation using, let me, start ventilation using high PEEP and high FiO2 generally, and titrate PEEP and FiO2 levels to achieve the desired KO2. I personally prefer the conservative PEEP FiO2 approach provided by ARDS.net. For the first hours, our goal plateau pressure is less than 30, while our target pH is more than 7.50. 15. In case of AMV failure to achieve appropriate oxygenation and ventilation, there are proposed rescue therapies. Prone positioning is the most recommended and promised approach. Unfortunately, we didn't use it at all, both lacking the equipment and acquaintance with this method. We generally use recruitment maneuvers, this patient using APRV as our favored method, using it between less than an hour 2 days based on its efficacy and tolerability for the individual patients. We use PCV with or without MBA, along with intermittent recruitment maneuvers as our last ventilatory effort, usually using inhaled pulmonary vasodilators such as NO or epoprostenol, and using ECMO are the proposed beneficial methods. However, we do not have any experience with them. Here we have staff protection means for mechanically ventilated patients, maintaining a cuff pressure between 25 to 30 centimeters H2O, and using close suctioning methods, providing tight seals for the connections, and using ETT clamping whenever patient disconnection from the ventilator should be done. Using HEPA filter on expiratory limb and HME before the ETT are recommended as well. Thank you for your attention. Here are our take-home message. While most of you are in fact in your homes already, protect yourself and the staff. Step up oxygenation strategies, intubate patients on time, and use low tidal volume ventilation strategies. Moreover, please take care. This is how you should care for an injured lung. It is fragile. Thank you for your attention.
Well, thank you very much, Dr. Safaei. Thank you. You briefly overviewed lots of aspects that we should keep in mind when taking care of these patients, from the breathing and ventilation, actually. The problem with intubation and mechanical ventilation of these patients is actually twofold. With most treatments that we recommend, it's the patient who either benefits or doesn't benefit, or perhaps is harmed by the medication. But with invasive ventilation and also intubation, we also pose a risk for the healthcare providers. There was a lot of concerns regarding use of non-invasive ventilation at the beginning because it's considered an aerosol generating procedure. And at the beginning, even in some protocols in some countries, I saw that the use of NIV was prohibited. And now it's gaining more and more popularity in taking care of these patients. And also intubation is becoming more and more as a later process in some countries. And some physicians try a non-invasive approach before they embark on the intubation of the patient. So these are important considerations, which again, different physicians from different parts of the world have experiences, and at times these experiences might not be in agreement necessarily. As you said, we here have little experience with prone positioning, although it has been shown to be probably effective in improving oxygenation. But the reason is that it needs equipment and expertise, as you mentioned, which is not quite common in most centers here. But this is something that we've heard and read about quite a lot. Well, like any other patient in critical conditions, these patients may need resuscitation. And our patient, unfortunately, suddenly collapsed, and there was resuscitation needed. There are 2 points that we should keep in mind. Why this patient might have suffered from this cardiovascular collapse? What causes might be more pertinent in these patients? And also, what considerations do we need to have when doing the resuscitation of COVID-19 patients. Dr. Mirfazaelian will tell us a little about this.
Hi, everybody. I'm Dr. Hadi Mirfazaelian from Department of Emergency Medicine. Sorry, I forgot to share my video here. Sorry. I will start video. Thank you. And I start sharing screen. Here we go. And okay, thank you. I'm Dr. Hadi Mirfazaelian from the Department of Emergency Medicine. I'm assistant professor here at TUMS, Tehran, Iran. And I'm about to tell you some stories and some points about the most critical moments you would experience, and one of the most distressing ones for the healthcare providers. Let's see the impact. Well, about 12 to 19% of the COVID positive patients would require hospital admission, and about 3 to 6% of them would become critically ill. And this is, kind of possible in this nowadays in this era, mostly because of the respiratory failure due to ARDS and the myocardial injury and infarction, and ventricular arrhythmias due to COVID-19 infection itself, or treatments such as hydroxychloroquine and chloroquine, and the QT prolongation, and the consequences. And the shock is also another cause, and the end result would be the cardiac arrest in most instances. But is it serious? Yes, definitely yes. We are about to perform many numerous aerosol generating procedures, such as chest compression, doing the airways, positive pressure, ventilation, and well, many people are around you like before, and there are some critical moments when the lapse in the infection control would happen. And after aerosol generating procedure, well, it's not safe to stay there. Viral particles would stay there on behind you about 1 hour. They have 1 hour half-life suspended in the air room. So it's serious, believe me. Well, now, foresight is better than hindsight. We have to do the preventive steps from the out of hospital. We have to do not carry the family members and other contacts of the patient with our hospital. And well, we have to consider the emergency systems should be considered, not transferring patient if the patient receive appropriate resuscitation effort before getting to the hospital, and no risk. Well, it should be think about before taking the patient to the hospital and exerting some additional risk. And also, out of hospital hand-only CPR is more acceptable nowadays, especially for the adult patients. I think you are all familiar with the algorithm of BLS and ACLS, but I would like to just highlight some new points. You have to be well equipped in the moment, and you have to limit the personnel in the room, in the scene, let's say. And you have to go to the, check for responsiveness and shout for help, activate the emergency medical system, and get the AED the job. And then again, see if there is any, let's say, the pulse and respiratory. And accordingly, you have to decide to do the breathing and compression. in case you are about to do the breathing, you have to do it. It's really important to bear in your mind that you have to do it with the bag mask ventilation, with the filter and the tight seal. The European guideline would say that you have to have two people in the place in order to, one, take the face mask tightly with both hands, and the other do the bagging stuff. And in case it's needed to go to the CPR, let's say chest compression is a hazardous job. You have to be well equipped, and the ventilation is like before. But if you are alone, you have to do the chest compression only. It's acceptable even in the hospital. And the other when no one else in the place, and the oxygenation could be provided with the face mask, non-reversible face mask. And if the AED arrives, you can do the defibrillation. And the good news is the defibrillation is not currently not considered aerosol generating procedure. And this is the figure how you can install the filtering stuff. And you have to insert a HEPA filter between the self-inflating bag and the tracheal tube, and another one in case it's possible in front of the PEEP valve between the the self-inflating bag and the PEEP valve. Otherwise, you have to close the PEEP valve in order to make a closed circuit with low risk of contamination. But let's go to the ACLS. Now, if you can see that the patient is about to be in the CPR situation, please do some proactive job and move the patient to somewhere close, and if possibly, preferably in the negative pressure room. The installation of HEPA filter and the bag mask ventilation is like before, but inline suction catheters are also recommended in this case. The compression is like before, but you have to have the best intubator person in place, preferably using video laryngoscopy, and insert the cough tube. And it is important to note that you have to pause the chest compression at the moment of intubation in order to, because of the safety issues. You have to have a tight seal, and when it's not possible to intubate the patient, it is acceptable, even in the ACLS, to have the passive oxygenation with non-reversible face mask. And the American said that American Heart Association says that you have to cover the non-reversible face mask with the surgical mask in adults. And in delayed intubation, supraglottic airways and bag mask ventilation is okay. They are kind of alternative in this situation. And the mechanical compression devices is also recommended, mainly in the prolonged chest compression. And here's the algorithm. You can see the changes, some new boxes in the yellow, and some changes with the bold letters. As you see, you have to have good equipment and consider if it is necessary to have the CPR for the patient or not. And you have to limit aerosol generating procedure and prepare for intubation. And before that preparation, intubation is kind of prohibited for the patient. As I mentioned before, the intubator should be the best person and should have the video laryngoscopy in their hand and do the intubation with the cough tube while the compression is paused. If the intubation is delayed, supraglottic devices and bag mask ventilation, and even non-reversible face mask with the covered let's say, the surgical mask is also acceptable. Consider a mechanical compression for the patient, and all the other stuff such as the rate, the depth, the rotation of 2 minutes rotation is like before, and it's also about the medications such as epinephrine and antiarrhythmias. I would bring up 2 special situations. The first one is a patient who are already intubated and under mechanical ventilation when he or she experienced the cardiac arrest. Interestingly, most guidelines, including European ones and American Heart Association and the British Resuscitation Council, would recommend not detaching patients from mechanical ventilators, but make some adjustment in order to have the ventilation by the machine. According to the American recommendation, you have to increase FiO2 to 100%, to change the mode to the pressure control ventilation in the assist control mode, and set the respiratory rate to 10, and turn off the trigger and alarm, and look for the good chest rise, which means 6 cc of per kilogram ideal body weight. And it seems that it's kind of expert panel opinion, and there are not so many references for that, but this is the recommendation in the interim guideline by the American Heart Association and European guideline. And about the special situation too, as we heard in these lectures, there are probably many patients would be found in the place like this, and they also would experience cardiac arrest and need some CPR. Well, American Heart Association would say do not turn the patient to the supine position unless you are able to do so without any equipment disconnection and risk of air sedation. Well, you have to do the chest compression in the back, in the T7 to T10 vertebral body, and you have to defibrillate patient in the anterior posterior position. This anterior posterior position is also recommended in European guideline, but you can attach the pads in either a mid-axillary line in the armpits too. Our experience is it was about a month ago when Iranian national guideline was published. Recommendations very, very similar, have a PPE closed room, but the prone CPR, passive oxygenation, video laryngoscopy, and so on. But interestingly, it's been endorsed to have only 4 personnel in the room, 2 nurses, 1 for the airway, a physician probably, and the other for the compression. This is the maximum persons allowed to be in the room during the CPR, and they have to be well equipped according to the standard protocols of personal protective equipments. To recap, we have to reduce provider exposure, don PPE before entering the room, limited personnel in the scene, consider using mechanical devices, especially in the adults, communicate with the new providers who enter the room to have a better safe conditions, and you have to lower risk of aerosol generating procedures, use the HEPA filter for the ventilation, intubate with the cough tube and air in the early phases, and connect it to the mechanical ventilator whenever possible. Have the best intubator in place, use video laryngoscopy, and pause the chest compression and intubate patient with the cough tube, and the HEPA filter, as I told you. And in delayed intubation, it's okay to have supraglottic devices or non-reversible face mask or bag mask ventilation. And during all the procedure, please take care to minimize closed-circuit disconnection. Thanks for attention, and I'm ready to hear your question and, if possible, to answer them.
Well, thank you very much, Dr. Mirfazaelian. The resuscitation of a patient who has contracted COVID-19 can be very distressing, actually, for the healthcare providers who have to be there. And at the same time, it's a very critical intervention that needs to be done immediately. And so we should be prepared for all the things that might happen. There are different situations which are unique for these patients. You might have to CPR a patient who's in prone position. You might have to CPR a patient who's connected to the ventilator, and you don't want to disconnect as much as possible to prevent the risk of spread of the disease. And you know that since this COVID-19 has been present, the fears of within hospital transmission has always been a concern. So these are important considerations when resuscitating a patient with COVID-19. Well, now that the presentations are over, we'll briefly review some of the questions posed by the audience. And I would like to ask the first question from Dr. Zehtabchi. We've had questions regarding the D-dimer and the use of D-dimer. The question was whether you check it to see if there has been a thrombosis, venous thromboembolism or something, or you just check it to see whether you are to administer anticoagulant to the patients or not. And another question which we'll be happy to hear from you is that the experience of most physicians is that those who undergo mechanical ventilation die, unfortunately. Although this can be attributed to the severity of the disease, do you think there might be other reasons for high rate of deaths among these patients?
Hi, thanks again. Yes, we tend to test patients for DVT, and we tend to, if we can, test them for PE. But as you know, patients with severe COVID, it's very hard to do CTA on them. It's very hard to do any diagnostic test on them, especially if they are in the ICU, they are intubated, or they are in prone position. So that's why many physicians use D-dimer to decide who to anticoagulate and who not to. Yes, D-dimer is elevated in a lot of patients with COVID-19, but in patients who are in hypercoagulable state, they are the levels are very, very high. So we anticoagulate patients who are have extremely high levels of D-dimer, above 2,000 or above 3,000. That's the question regarding D-dimer. We really don't know how intubation contributes to death. As you mentioned, it's probably because patients who get intubated are sicker and at baseline. But there should be some other mechanistic explanation for this that at this point we do not know.
Well, thank you very much. Yeah, this has been a concern. Several people from our audience has actually posed these questions, including one who was joined us through our Facebook Live presentation. So one of the people has also asked about Iran's experience with plasma transfusion. Dr. Zehtabchi talked about the issue of convalescent plasma transfusion, and mentioned that there is no good evidence supporting the use of it, and the anecdotal reports are different from institution to institution. In our case, as much as I know, other colleagues can help me, we don't have much experience with the use of convalescent plasma, and so we cannot, again, make any sound judgment regarding the use of that for this purpose, but I would be happy to hear if any of our presenters have experience with this.
Let me clarify that I said we don't have any good evidence that it has any benefits, but we are waiting for that evidence, and we are, absence of evidence is different from evidence against. So we don't have good evidence that it works or it doesn't work, but we are hoping that the trials that are being conducted will show us whether this treatment is effective or not. We are hoping that at very least some patients or some subgroups of patients are benefiting from this plasma transfusion.
Yeah, thank you very much. It's a very important point, actually. The next question is for...
Excuse me. Used convalescent plasma in a few cases, though they were all very bad cases, poor cases with poor prognosis, but all of them died shortly afterward. No recovery was observed among them. Tried for 4 patients.
Yeah, personal experiences with this treatment varies considerably, and as Dr. Zehtabchi said, we will have to wait for the evidence to come, and we better hope that it works, or at least one of these things that we do work finally. The next question is it's for Dr. Vahidi. Sorry. One of the people asked about the time period for CT findings. Is there a temporal relationship between CT findings and the course of the disease, and in what way can it help us?
Unfortunately, because of the lack of evidence, answering to this question is somehow hard. But CT scores a number of zones involved progress rapidly, peaked during illness day 6 to 11 with a median day of 5. And it's usually progressive, and patients' clinical presentation and also the CT findings deteriorate very soon.
Well, thank you very much. Well, yes, we expect the changes in the lung parenchyma, and as we see them in the lung CT scan, to change from a ground glass pattern to more consolidation, but this is not something that can be expected for sure, but this is the pattern that most commonly seen, that interstitial pattern changes to a ground glass pattern and then to a consolidation. And there has been some suggestions regarding how time might affect these findings, but it still needs to be studied more. Dr. Safaei, I guess the next question is for you, and it's about the low tidal volume strategy and why is this strategy recommended, and also about whether intubation might have posed a risk to both patients and also healthcare providers during the earliest stages of the pandemic, when there were probably more intubations than now. Do you think that it poses a risk for patients and healthcare providers? And also the question on low tidal volume strategy.
Thank you. For the low tidal volume ventilation strategy question, this is called the open lung approach to ventilation, giving the patient low tidal volume, aiming to minimize alveolar overdistension. The alveoles are injured before, and we don't want to overdistend the injured alveolar to with more injury. And the PEEP, giving high PEEP, minimizing cyclic telectasis between each respiratory cycles. It has a very good evidence, strong evidence in other kind of ARDS, and we've seen patients do well when we try the same strategy for them in the COVID patients. And the second question, at least in our experience, it doesn't tell us so. Patients, we try to not intubate despite being on a poor condition. All were died despite our best effort. It seems the worst patients, the patients with worst conditions will be intubated, and the deaths among them are high. My experience, my limited experience, doesn't tell me that the intubation or mechanical ventilation itself kill anybody, but the patients with the worst condition will be intubated. I hope I give
Thank you very much.
Answer.
Thank you very much, Dr. Safaei. Well, as you said, the low tidal volume strategy is something which has been used in most cases of ARDS, and so we rationally expect it to be also useful in patients with COVID-19 involvement of the lung. The next question is for Dr. Mirfazaelian. Someone has asked you to share again the slide with the bag mask ventilation and HEPA filter and how they're connected. And meanwhile, there is another question regarding hand-only CPR and how it can be used for COVID-19 patients. Explain a little more about that. I guess the question was how this might happen in real life, and that's not very surprising. Someone might be taking care of a patient who has COVID-19 at home, and the patient may collapse, or other situations. But explain a little more about that, and also share with us that slide that has been requested.
Sorry, I forgot to unmute. To be honest, it's sorry again. Okay. It's real depends on this is the slide, just a picture, but it's really depends on the type of the bag mask and so on, the manufacturers, and for example, ours is more like the left side, which is not having any PEEP valve, which can be have a HEPA filter in between the PEEP valve and the exhaust valve. But with the simple adapters, which is readily in place, probably you can find them while using your mechanical ventilators and connecting mechanical ventilators to the patients. You can find out the equipment needed for making something like this in your place in your hospital, and it's important to do it beforehand. But the question about the next question you asked me about the hand-only CPR. Yes, it's very difficult. I think it's about to finding out if the patient is suffering from coronavirus infection or not. It's very difficult, as all of us nowadays see a lot of patients who are have another problem, for example, hand laceration or something else, and come to the hospital and they would be diagnosed with the coronavirus nowadays. But finding someone collapsed in the street and knowing if he or she is suffering from COVID-19, well, kind of impossible. I don't have a clear answer for that. But well, if it's possible, if you know for sure that the patient has got the COVID-19, or probably is he or she is suspicious for that disease, well, it is recommended for adults to do only hand-only CPR in out of hospital scenes. Well, I think I hope I have answered your question.
Thank you very much. And Dr. Zehtabchi also wants to add a comment about the CPR in these patients.
Yes, thank you. I really enjoyed the presentations, and particularly the CPR presentation. But I want to point out one important factor, and I want everyone who works with COVID patients to think about this before doing CPR on COVID patients. We are all emergency physicians. CPR is what we do best, and therefore it's very easy for us to jump on and start resuscitating patients who experience cardiac arrest. But several observational studies and also in our personal experience, many studies have shown that the chance of survival from cardiac arrest after COVID is almost zero. So it is helpful for all of us to step back and think about the outcome of CPR before we go into the room or before we are starting CPR, because we are going to expose a lot of our staff to harm and risk of infection in a procedure that really has limited benefit or was really near zero chance of survival, especially for patients with comorbidities and patients with or elderly patients. So in our experience, we now have started this discussion with the patients early on. As soon as they come and they are in respiratory distress or they have high-risk patients, we start talking to them and discuss with them the possibility of do not resuscitate, do not intubate orders, and give them an option to them, or if they cannot make that decision, to their families. And we try to avoid resuscitating, especially high-risk patients, as I said, because the chance of survival is near zero, and there is a lot of risk for the staff. And I would love to hear the panel's opinion on this.
Thank you very much. Very important point, because whenever we do a CPR, we have to be careful not to provide futile care to the patient. And in the case of COVID-19, it's not only futile, it might not only be futile for the patient, but also hazardous for the healthcare providers who are taking care of the patient. So this is very important to keep this in mind. Well, as you know, and most of our audience probably know, in Iran, we do not have that do not resuscitate order yet in place. So the patients cannot actually have a directive or advance will about that. But still, it's at the discretion of the physician to stop or to withhold CPR if the doctor considers the CPR to be futile and imposing only a risk to people who are taking care of the patient. And this is very important. So ask for the CPR when it is needed. It should be done very, very cautiously with all the precautions. Even the American Heart Association has asked not to start CPR unless you have personal protective equipment, and this is very important. And when it seems to be futile, which is very likely in case of severe COVID diseases, especially with comorbidities, it's very important not to start the CPR, which is going to be futile and only dangerous for the healthcare providers. Thank you very much. There's also another question about the correlation between COVID-19 and malaria. I personally have no opinion about that. I wonder if any of the panelists have anything to say about that. As far as I know, the reason might be that some anti-malaria drugs, such as hydroxychloroquine, are used for the treatment, but I haven't heard anything else about the relationship between the two. Dr. Safaei,
Can I answer?
Yeah, sure. Go on.
It has some antiviral activities before known, and studies showed in vitro antiviral activities, but we do not know if those antiviral activities work or the immunosuppressive or immunomodality effects of the hydroxychloroquine, which helps in SLE and RA works, but the proposed mechanism of effect is one of those antiviral activity or anti-immune activity of hydroxychloroquine.
Thank you very much. Well, and
You're welcome.
there is one last question about the L-type and H-type ARDS, and the question has been forwarded to Dr. Zehtabchi, but also other colleagues can also help if there is any study about that or any points about that. I haven't heard personally about it.
I believe it's too early to say, but some studies have suggested that the ARDS that we see in COVID-19 patients is actually pseudo ARDS, is not real ARDS, and that since we are treating these patients similar to ARDS, that could be one of the reasons why the intubated patients do not do well. So because the Berlin definition for ARDS is very broad, many patients fall into definition of ARDS, but it's been proposed that probably what we see in COVID-19 is not real ARDS, is pseudo ARDS. So this is something that remains to be investigated, and hopefully we will learn more about the types of ARDS in COVID-19, if it is ARDS or if it's a different entity, and hopefully that will guide our treatment. But at the moment, we believe that this is the pulmonary findings in ARDS is not in COVID-19 is not real ARDS, and it's that's why it's called pseudo ARDS.
Well, thank you very much. This is a very important point, and we need to have more and more pathologic findings probably to be able to comment on this, but this will certainly change the way we treat these patients, and it's a question to be answered for sure in future. We've passed 8 minutes beyond the time limit, and I want to ask the presenters if they have anything to add, and otherwise we'll call it a day. Well, thank you very much for joining us. I also thank again Dr. Zehtabchi, who has taken the time to join us. I know he's been on duty for the past days, and he's working very hard these days. There's with fighting with COVID-19. Things have a little slowed down here, but are still quite hard in New York. Thank you very much for giving us your time. And I also thank other presenters and also the audience for joining us. And have a good day, everybody.
Thank you so much.
Thank you.
And thank you, everyone.
Thank you.
Thank you, everyone. Goodbye.
Goodbye.